The following podcast is part of a certified educational activity titled New Kids on the Block in mHSPC, Personalizing Approaches Through Emerging Precision Therapies. Access the entire activity and complete the post-test at peerview.com/WBF860. Downloadable slides and practice aids are also available.
Hello, I'm Dr. Joaquin Mateo. I'm a medical oncologist at the Vall d'Hebron Institute of Oncology in Barcelona, Spain. Welcome to this educational activity entitled New Kids in the Block in Metastatic Hormone-Sensitive Prostate Cancer, Personalizing Approaches Through Emerging Precision Therapies. Thank you for joining us. Today we have a multidisciplinary team. I'm pleased to be joined by my colleagues, Professor Noel Clark, urologist from the UK, and Professor Isabella Werneck, a pathologist specializing in urological cancers from Brazil. Professor Clark, would you like to introduce yourself, please?
Thank you, Joaquin. My name's Noel Clark. I'm a urological surgeon and Professor of Urological Oncology at the Christie Hospital in Manchester. And I'm looking forward to discussing the new kids on the block.
Thank you for joining us, Noel. Professor Werner, thank you for coming here today with us.
Hello, everybody. It's a pleasure to be here. I'm a pathologist from Brazil. I'm specialized in uropathology and also molecular pathology. And it's going to be a pleasure to talk to you about these new biomarkers in prostate cancer.
Thank you both for joining us today. I'm sure it's going to be a great discussion. The objectives for today are to discuss the critical clinical evidence and therapeutic indications supporting the use of combination regimens for the management of men with metastatic hormone-sensitive prostate cancer, to discuss the appropriate biomarker assessment that can help us guide treatment selection for these patients, and last, to discuss about how to develop personalized therapeutic strategies that incorporate treatment intensification based on rational biomarker-directed therapies. So throughout this activity, we're going to be sharing downloadable tools and practice aids that will help you, we hope, think through these new approaches for individualizing treatment options and for how biomarkers can be used in both predictive and prognostic approach to help us better treat patients with metastatic hormone-sensitive prostate cancer. So let's get started. It's important to stress how the treatment paradigm has changed in the last decade when it comes to managing men with metastatic hormone-sensitive prostate cancer. Throughout the last 10 years, we have seen several clinical trials clearly demonstrating that intensifying therapy, meaning adding more treatment beyond solely ADT for men with metastatic hormone-sensitive prostate cancer, can help improve prognosis from this disease. Since the early trials that demonstrated that the addition of docetaxel can improve overall survival compared to using ADT alone, to all the several trials that have shown that the combination of ADT with abiraterone or AR inhibitors such as enzalutamide, apalutamide, or darolutamide also lead to improving the survival of these men. More recently, we have also seen trials using the triplet therapy combination, combining ADT, an AR inhibitor or abiraterone, and docetaxel used as 6 cycles of chemotherapy, are resulting in improved outcomes, although we will discuss also today how this can be further improved by using biomarkers. So, are these treatments being used in our day-to-day practice? We have developed all these trials in the last 10 years, but is this changing the treatment of men who are coming to our clinic every day? But you can see that there is still a significant number of patients who are still receiving only ADT. And some of them may be just because of comorbidities. That may be the good thing, the right thing to do. But for many other patients, we all worry that maybe we are not really translating the clinical trial data into practice. And building from there, can biomarkers help us do even better for our patients? We have seen, in particularly in late stage metastatic CRPC, how biomarkers can help us identify better treatment approaches for some patients. Can we move this concept also to the metastatic hormone-sensitive scenario and use genomic or protein-based biomarkers to guide treatment decisions? Despite these therapeutic advances and the fact that we have improved the survival of these men, most patients with mHSPC ultimately become castration resistant. So there is a need to continue developing new therapeutic approaches for these patients. Established approaches with therapeutic impact in mCRPC are being moved earlier and earlier to the mHSPC scenario. We have seen this with docetaxel, with ARPIs, but now we are seeing clinical trial data for AKT inhibitors, for PARP inhibitors, or for radiopharmaceuticals targeting PSMA that have been tested in the hormone-sensitive space. Would this drug help patients and improve their survival? That's what we're going to be discussing today. So before we go into the specific discussions, I'd like to ask my colleagues about their opinion on how this field is moving forward. So treatment intensification has become a cornerstone of current guidelines, but as we just said, we're still facing questions for patient selection, for treatment sequencing, and this intensification is still underused in many occasions. So Professor Clark, from your perspective, what are the biggest challenges that we are facing in clinical practice to truly identify those patients who benefit from intensification strategies?
Well, thank you, Joachim. There are a number of challenges which we have to deal with. I think the first thing to say is it's great to see so many options coming through from randomized controlled trials. However, it is important to recognize that randomized controlled trials are usually recruiting from relatively fit, relatively young patients, and they don't necessarily represent what's actually happening in the real world. And so it's important to take the information from those trials and to use it on our patients in a sensible way.
And we'll be scrutinizing the data for some of these biomarkers and drugs in a second. But before we start, and I want to ask you both as pathologists and as uro-oncologists, maybe we start with Professor Werner. How is your diagnostic pathway changing? I mean, how is your approach to prostate cancer diagnosis changing because of the availability of these biomarkers?
Well, it's changing in so many ways. Even when the surgical specimen or the biopsy arrive at the lab, so now it's crucial, like to take care of this material, to properly process this material in order to guarantee that the molecule, the DNA, the proteins is good for molecular testing. So care about the material, even starting in the OR, so to keep it well fixed all the time.
So let's go now more in deep to analyze the suite of new testing strategies that can guide clinical decision making in this new era for the treatment of men with mHSPC. So Dr. Werner, can you please walk us through some of the tools that we already have?
Well, so the first thing when we talk about biomarkers, we have to realize what are we looking for. We know that from the biology perspective, we have a DNA molecule that transcribed to RNA and translated to protein. And all these molecules can provide precious information regarding molecular tests. So we still know that Gleason score is still the main prognosis factor, but many other things now the pathology has to put in the report, especially to guide molecular testing. So, for example, the presence of cribriform component or intraductal carcinoma, they are all characteristics of high risk tumor. So we will see that sometimes we will use this information to establish if a patient goes to a germline test or not. But The biomarkers, we can divide nowadays in two types of biomarkers. Tissue biomarkers, that the ones that we do not destroy the tissue, so the pathologist is still looking slides to reach the molecular defect, like immunohistochemistry or in situ hybridization. And when we talk about DNA sequence, for example, biomarkers that we would do molecular profile, now we have to, let's say, destroy this tissue in order to extract the DNA or RNA to look for particular mutations or fusions or other molecular alterations. I was discussing before, the tissue is very important right now because we have to have these molecules in good quality in order to achieve all these biomarkers. So fixation is very important. So we use worldwide using buffer formalin, and this material have to go to this fixative as fast as possible. So as soon as the material was taken from the patient, it should be put in buffering formalin. When we talk about prostate cancer, we have a particular point of attention regarding material. Since we know that 70% of patients with metastatic prostate cancer will have bone lesions, and sometimes the only metastasis that they will have is bone. And when we decalcify this material in the lab, in order to see an H&E and to cut the material, sometimes we use like very XD substance like nitric acid or some other types of acid, and it will destroy the molecules. So when we receive nowadays a bone biopsy of prostate patients with the question, is it a metastasis? So the pathologist should be aware that probably this material will go to molecular test. So we should like discalcify this material in a different substance that we call EDTA. That's the same that we use nowadays for decalcify, for example, bone marrow. So they will allow to keep these molecules more properly for molecular tests. So PTEN deletions is usually related to a more aggressive tumor. So as higher the Gleason, the higher the chance that we have PTEN deletions. And we could achieve this status easily by IHC, as we show in this in the bottom picture when we see tumoral cells without PTEN expression. And the other biomarkers that we can use to predict different treatment is genes from the homologous recombination repair, especially BRCA1 and BRCA2 genes. So over 12% of patients with metastatic prostate cancer had BRCA1 or 2 alterations. And besides that, we have another 60% of patients had another gene alterations in another homologous repair genes. So it's crucial to test for these mutations in order to select patients for specific therapies. So how to test these alterations? So as these alterations are more frequent, like a punctual mutation, we have to do this sequencing of the DNA. So we can't use FISH, we can't use IHC, we have to sequence this material. And there's different approach. We can test germline, we can test somatic. How should we do? So it depends. Ideally is to test both, but we know that sometimes because of cost, it depends on where in the world you are. You may have problems with technologies. So the ideal is to test both. So my take-home points for this the testing of those biomarkers. So if possible, use material from the actual disease. So if you have like the metastasis available, it's easier to biopsy. So let's say that it's better to use the material because for some genes, for example, PTEN, it will change along the way. So I started to say that around 20% of patients has PTEN deletion in the primary. When the disease progression, it can reach like 40%. So always try to use the actual disease. But for some genes like BRCA1 or 2, their alterations are very precocious in the carcinogenesis in prostate cancer. So if the mutation is there as when the patient performed the prostatectomy, it probably will not change along the way. So the ideal material is the most recent, the best preserved, not decalcified, and more abundant in tumor cells. When using bone material, prefer is decalcified in EDTA and let the pathologist know if a biopsy was obtained for molecular test because they can change the protocols they use to process this tissue. Take in mind that IHC is always faster, cheaper than in situ hybridization and NGS. So all biomarkers that we can use, the protein approach is better, and always collaborate to ensure the integration of biomarker testing in the future. So talk to the pathologist. Nowadays, the pathologist is not that doctor that stay away in behind the scenes, looking behind the microscope. So talk to your pathologist to check the best approach when and which material is best for the molecular testing. Thank you.
Thank you, Isabella. We keep this last concept, collaboration through the multidisciplinary team to improve the pathways for patients. So we'll go now one by one through the latest data for drugs targeting 3 key biomarkers in prostate cancer as PTEN deficiency, HRR mutations, and high expression of PSMA by imaging biomarkers. But I'm showing this cartoon because one concept that we really want to pass to the audience today is that, as Professor Clark was saying, we have to approach patients as a whole. A tumor is not just defined by a biomarker and it's not just defined by a clinical variable, but it's the combination of both and the integration of all of them that will help us make the best decisions for patients. So let's start with PTEN as a biomarker. Professor Clark will guide us through some of the latest data for AKT inhibitors in PTEN-deficient prostate cancers.
Thank you, Joachim, and Isabella for that overview of pathology, fundamentally important. Now, PTEN is related to what's known as the AKT pathway. And the AKT pathway is one of the driver pathways for prostate cancer and indeed other cancers. It's been known for many years, and our understanding of how it can be inhibited is getting better, and particularly with newer data which has just become available to us. So PTEN is a proficient hormone-sensitive in tumor cells and is one of the key drivers. And you see in the cartoon on the right that we all know about androgen receptor signaling and its importance in driving prostate cancer and how that can be inhibited. With the PI3 kinase AKT signaling pathway, you can see on the right where capivasertib, which is a drug which has been tested in a large-scale phase 3 trial, which I'll show you in a minute, inhibits that AKT pathway. So for prostate cancers that are becoming castrate-resistant, in other words, less responsive to the androgen driver, then the AKT pathway is really very important. In PTEN-deficient tumor cells, there are additional proliferative drive from the upregulation of that pathway, and that complements the androgen signaling. And, of course, it's associated with the poor prognosis in this group of patients. PTEN-deficient patients will do worse in the long term. Their survival is much shorter. Capivasertib is a potent selective inhibitor of the 3 AKT isoforms, and there was phase 2-3 evidence showing benefits with another AKT inhibitor, ipatasertib, which was given in combination with abiraterone in P-deficient metastatic castrate-resistant prostate cancer. And that really was the initiator for the development of a phase 3 trial. And this is it, Capitello 281. You can see on the left of the schema, patients with PTEN deficient de novo metastatic hormone-sensitive prostate cancer. And that's important because what we found with virtually all the treatments that have been successful in late stage, bringing them earlier in the disease pathway results in a better outcome. And this is why the trial is planned for the hormone-sensitive space. The tissue from the patients was tested for PTEN deficiency, so there's a diagnostic cutoff of over 90% of viable malignant cells with no specific cytoplasmic staining by immunohistochemistry. And Isabella has told you the importance of that and how relatively straightforward that is in a good pathology lab. But of course, in a patient trial like this, we have to test a lot of patients, 6,200 submitted tumour tissue, 97% had a valid immunohistochemical test, and 25% of the patients were PTEN deficient. And they were stratified according to charted criteria for volume on standard imaging and also geography, which is an important event because in many published trials, patients are drawn from a relatively limited population, particularly ethnicity. Of the 1,012 patients randomized 1-to-1 to capivasertib and abiraterone plus prednisone as the ARPI, they were matched against placebo with an active control agent, abiraterone. And of course, all the patients got ADT in conjunction, so they were on doublet therapy plus the intervention. The primary endpoint, radiological progression-free survival with standard endpoints for a trial of this nature, overall survival, time to first subsequent therapy, and so on. And importantly, there was an exploratory post-hoc analysis looking at the effect or efficacy in PTEN deficient groups. If you look at the study timeline on the bottom, it's important to recognize that the patients now, the trial, should I say, is now enrolled fully, but the current analysis is the primary data cutoff as of the 7th of October 2024. So some of the data is still to come, particularly the maturity in relation to overall survival. And here are some of the results. These were presented at the ESMO conference just recently and published synchronously in Annals of Oncology, and that's available to you online. This is showing the primary endpoint of the trial, the probability of radiological progression-free survival, capivasertib and abiraterone in green at the top, and placebo and abiraterone at the bottom. And there's a clear separation in the Kaplan-Meier effects, in the Kaplan-Meier curves. You can see that the curves are starting to separate at about 12 months. By 24 months, there is a separation, and by 33, 36 months, we have a 7.5 month difference in the two arms of the study, with a hazard ratio which is very clearly beneficial, 0.81, and a p-value of 0.034. When we look at the post-hoc analysis, looking at the intensity of PTEN deficiency histologically, we can see that there's a relative difference in the efficacy of capivasertib and abiraterone. This is shown again in the post-hoc analysis with this forest plot. With this on the left, you can see the PTEN proficient, which is more and more reliant on the PI3-AKT pathway for its driver and the benefit of inhibition. So as the staining gets more intense, the potential benefit of the therapy combination gets greater. Of course, importantly, in use of combination drugs like this, the safety profile is really important. And that was consistent with each individual drug profile. Most commonly, we're used to these side effects with abiraterone. They're well managed and relatively well tolerated in most patients. The most common significant adverse effect with capivasertib was rash and hyperglycemia, which is an expected class effect with AKT inhibitor drugs. The other thing which is important to note, if you read on to the paper in Annals of Oncology, is the dissociation of the composite endpoint from PSA. What we saw was that the PSA was not necessarily the best indicator of response to the combination with the AKT inhibitor. Rather, endpoint measurements like skeletal events and radiological progression were of greater relevance. So, our take-home thoughts for a patient with PTEN deficiency on the basis of this analysis and presentation of data from the data cutoff 1 from the CAPI 281 trial is that PTEN deficient metastatic hormone-sensitive prostate cancer has a worse prognosis. We know that. AKT is a driver of disease progression in patients with loss of PTEN, and AKT inhibition has a clinical effect, and this is a promising new clinical avenue and a new clinical tool available to us. We need more mature information from Capitello 281, and that will be forthcoming. The PTEN testing in high-risk mHSPC patient population is likely to be important in the future in order to direct treatment, and that really is an illustration of where we need to talk to our pathology teams. Thank you very much.
Thank you, Professor Clark. So this was a good overview of the latest data for PTEN-deficient prostate cancer. We're going to move now to the subset of patients whose tumors harbor mutations in the HRR genes. We know that the presence of these HRR gene mutations, and particularly BRCA alterations, associate with poor prognosis. We had data on the CRPC space for that. We also had data in the localized prostate cancer setting, but we also have this nice paper that came out in Annals of Oncology earlier this year from the David Olmos and Elena Castro group, showing that also in metastatic HSPC, those patients with HRR mutations, particularly those with BRCA alterations, have significantly worse prognosis, and that's an independent prognostic factor to disease volume or treatment regimen, meaning that is really clinically relevant across the disease spectrum. That vouched for early HRR mutation screening, for example, for identifying patients that may merit hereditary testing, but also for developing novel targeted treatments in this population. We know that PARP inhibitors improve outcome of patients with these mutations in the CRPC space. So the obvious next question was, would PARP inhibitors improve the outcome of patients with HRR mutations in the HSPC space? And to that end, several clinical trials have been launched in the recent years. On the one side, the phase 3 Amplitude trial has tested the combination of niraparib and abiraterone compared to abiraterone alone, of course, in both cases with a background of ADT, in men with mHSPC and either germline or somatic HRR gene alterations. The TALAPRO-3 trial has tested a very similar patient population, but in this case, interrogating the effect of combining enzalutamide with talazoparib, another PARP inhibitor, compared to enzalutamide with placebo. In both cases, Amplitude and TALAPRO-3, the primary endpoint is a radiographic PFS with overall survival as key secondary endpoint. We still have to wait a few months to see data from TALAPRO-3, but at ASCO 2025, Professor Attar presented the primary endpoint analysis of the Amplitude trial that has now been also published in Nature Medicine. In this trial, the investigators demonstrated that the addition of niraparib to ADT and abiraterone improves outcome for men with metastatic HSPC. We are still waiting for mature overall survival data on this trial, but this is the first data suggesting that PARP inhibitors may play a role in treatment for men with mHSPC. There is a third trial going on, the EVOPAR PR01 trial, that is testing saruparib, a PARP1 selective inhibitor, in combination with a physician choice of ARPI, so not restricted to one or another drug. Moving to the third family of biomarkers that we wanted to discuss today, we're going to talk about PSMA expression measured using PET scan. So PSMA PET uptake as a prognostic biomarker. We know it has prognostic value in CRPC, but also as a predictive biomarker for treatment with lutetium-177 PSMAs with Pluvicto. We know that lutetium-177 PSMA improves outcome, has demonstrated to improve OS in very late stage disease when tested pre-chemotherapy in the CRPC space demonstrated to improve PFS, but no changes in OS. So the next question was, well, what's the impact when treating patients with lutetium in the hormone-naive setting? The phase 3 PSMA addition that was reported at ESMO a few weeks ago in Berlin tested the addition of lutetium PSMA to the standard of care, meaning ADT and an ARPI, in patients who had a positive PSMA PET scan. Those patients in the interventional arm received up to 6 cycles of lutetium every 6 weeks at the standard doses. The primary endpoint was again rPFS, and overall survival was the key secondary endpoint. At ESMO, we saw the results for the primary endpoint. There is a significant improvement in rPFS for patients receiving Pluvicto on the top of the doublet of ADT and ARPI, but it's still very early to assess overall survival. In fact, the maturity was really low, with less than 30% of events, and so far there was no clear signs of improvement in overall survival. But again, we need to wait still some time to get longer follow-up and then understand what's the true impact of this compound in the HSPC space, and also probably to understand how to better prioritize patients for this treatment. Is probable that the definition of PSMA positive disease that we are using in clinical practice nowadays is still too broad, and that there are means to identify those patients who are more likely to derive a bigger magnitude of benefit from this compound. So a lot of data eagerly awaited in this space, both for PARP inhibitors and for radiopharmaceuticals targeting PSMA. I think that the next 1 to 2 years, we are going to have this data, and we're really going to reshape the management of mHSPC. So based on this data, I like to hear the opinion of my expert colleagues in how to combine and sequence the treatments that we already have for HSPC in the context of these new targeted approaches, and how do these biomarkers help us select between all the therapeutic options available now for our patients.
I think we need to give the patients the best chance, and if we do that by biomarker-driven approaches, then we can stratify for the best possible treatments for them. And I think the third point, which is an important point for many countries whose healthcare systems are struggling financially, is that these treatments have got to be affordable. So where does that leave us with the information we have? Well, the information that we can see with the P10 inhibition and with the PARP inhibition trials, or trial that is available to us at the moment, is that it looks promising. But we have to be cognizant of the fact that patients with mHSPC live longer than patients with mCRPC. And so toxicity we need to be careful about, and that needs to be anticipated, it needs to be measured, it needs to be managed.
Good point. And actually, it's important to remember that also these biomarkers are not only predictive, but also prognostic, meaning they identify patients with a more aggressive course of disease. So I think that we also, as a field, need to generate the data in how they can inform the use of the options that we already have, even beyond targeted therapies, right? So, Professor Wernick, you mentioned collaboration and communication before. So with the array of emerging precision options for mHSPC, how is this communication between different specialists going to improve patient care and empowering patients in the shared decision-making process?
Well, so the oncology and pathology are closer than ever. So it started with other tumors, such as lung, for example. Today it's impossible to talk about longer treatment without a pathologist talking with the oncologists. And for prostate, it will happen the same, especially in selection of which material that we should test for prostate cancer. So sometimes you do a bone biopsy, but the material is not proper for molecular tests, but we can reach the primary. Sometimes the For example, in prostate biopsy, we have sometimes different Gleason scores in the biopsy. So which one we are going to use for the molecular testing? So these communications back and forward for what the proposal of the molecular testing, what drug you're going to use, even to select. Sometimes I receive like do fish for P10, and I said, why not IHC? So this information, it's crucial to choose the best tests, the best patient, and with less cost. As Dr. Clark said, so cost has become a really important in oncology today. So in the molecular testing are the same. So this kind of discussion to not do the wrong test and unnecessary test is very important. So this connection is really important.
And my last question to Professor Clark, because we're running out of time, you mentioned access, right? And accessibility to testing. Your thoughts on how this data impact referral pathways and making tests available for patients?
I think it will become more widespread. It has to become more widespread. And in enabling that, we have to have champions like you and Isabella who will really drive this in their own institutions and in their own areas. So in a big city like Barcelona, well, there are lots of peripheral hospitals, and you're going to be leading that, just as we at the Christie in Manchester are leading in genetic testing for the area. And there are other examples of that. So we have to spread the message, if you will.
Perfect. So work with your local communities to make these advances available to patients is a good message to conclude. Thank you both for this fruitful discussion. So in summary, we have learned about the evolving precision-based approaches for our patients with mHSPC and how the multidisciplinary team is essential for navigating optimal outcomes. Thank you to everyone attending for joining us today. I'd like to remind you to download the practice aids associated with this educational activity as a resource for you and your teams and also for your patients. Thank you again, and we hope that you found this activity informative and useful for your clinical practice.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education, and by the European Board for Accreditation of Continuing Education for Health Professionals. This activity is supported by an independent educational grant from AstraZeneca. To access all materials for this activity, visit peerview.com/WBF860.